Hi, I'm Dr. Mohan Thomas. It must be Wednesday. Of course it is. Today I'm going to be talking about something really interesting. And it's one of my favorite things to do is to teach people. I'll start off with my line, which is if you look good, you feel good. If you feel good, you live longer. So looking good, feeling good, living life is what I'm all about. And I hope all of you are the same because your lives will be that much better. So today I'm going to discuss with you a very, very interesting case. We had a gentleman in his late 20s who came in with a pain and swelling of the right forearm. Like good medical science or good medical practice suggests, you feel it. It seems to be discrete in the sense that it is fading off into the arm, but you can feel around it. You feel that it is soft, somewhat tender, and a little movable. The first thing you need to do when you see a patient like this is have some thoughts. So I looked at it, location-wise and clinically. It had all the makings of a large lipoma. What did I do? Now this fellow is not very wealthy, so I went with the most reasonable form of imaging, which was an ultrasound. The ultrasound came back as low echogenic pattern, suggestive of a lipoma, but with a lot of cystic degeneration. So yesterday, I took him in, we did it in our office because poor guy couldn't afford the hospital and everything else. So according to me, the lipoma was about 8 centimeters by maybe 6 centimeters by 2 centimeters deep. So with the actual prepping of the forearm, I marked the area, proceeded to ring block it. Then I used tumescent liposuction, or rather tumescent infiltration, to go under the what I thought to be believed to be the inferiormost part of the lipoma. Went all around, got good anesthesia. Then I went ahead and marked the area, looked for some sort of fluctuance somewhere, and I found a little fluctuance in one area, and I made a mark there, a vertical mark, which was going to be my incision site. Waited a good 10-15 minutes for the local anesthesia to work. Tested and made sure that the anesthetic area was truly anesthetized. And then using the number 15 blade, I opened up right through skin. Then I took a curved hemostat and started opening up, and out came a cheesy material. So there is a doctor out there called Dr. Pimple Popper, and I've seen somebody, a good friend of mine, Dr. Jacob Hayavi, who recently not too long ago showed a video wherein he was able to express and squeeze out the lipoma. So what I did was, rather than squeezing it out, I used pressure, guided pressure, using a straight hemostat from one end and steadying the lesion with another on the other side. And out came loads of soft, cheesy material. Initially it was kind of liquid and of a dark color, and then it was mottled, and then finally, after a good 10, 15, maybe 20 minutes, most of it was expressed. Then using a large scoop, I made sure that all the soft tissue was expressed out of the small incision. Following which, I went ahead and this time I took a curette, a sharp curette, starting to curette out the so-called lining, because all lipomas are pretty discrete in terms of having a good lining around it. So I was able to find, it didn't come out in one piece, but it came out in several large segments. I was then looking down at what I believe to be the fibers of the biceps muscle, not the fibers, but the fascia overlying the muscle, the biceps muscle. This particular lesion had worked up its way cephalad, caudal, medial, and lateral to a depth of about 3 plus centimeters. The next important thing to do is to really irrigate the lesion, which is a cavitation. It's a cavity. So using a mixture of hydrogen peroxide, betadine, and saline, it was really irrigated profusely. It was nice and clean. The bed was pink. All shreds of cystic material that I could feel and see, I was able to get out. This was a small entry to a very large cavity. So you're restricted in some ways. You know, this is a lipoma. The worst that can happen is this procedure will act like a marsupialized lesion. And even if it grows back, it will be a small one. My guess is it is probably well managed and you won't get a recurrence. And even if you do, it'll be small. If I had to enucleate this cyst, I would have to make an incision, probably a good, 14 or 15 centimeters. Go to a hospital, general anesthesia, dig here, dig there. Now, I want to let you know that right through the procedure, I didn't hear a peep out of this patient because they're totally anesthetized and very comfortable. So after cleaning out the lesion, I could identify, I could see the medial and lateral aspect of it. Medially, there was the fascia overlying the biceps muscle. Then the lesion dived in between the biceps and the triceps, again maintaining, that the fascia was intact. There were no bleeding points. I could feel it went up quite a bit, and cephalad and caudal too, medial and lateral. I couldn't see the cephalad part. I couldn't see the caudal part or the cephalad part because it was too deep. The incision was very small. So what I continued to do was clean the whole area out, and thought of my plans and how should I close this now. We can't leave a cavity, nor can we pack the cavity and keep pulling out little at a time, none of which is practical for a guy who's got to work for a living. So I took 3 points of the edge, nice deep bites of the edge of the incision, tacked it down to the muscular fascia, and brought it up there and buried my knot. And I got the first closure, deep closure, using 30 or 20 Vicryl. I think it was 20 Vicryl. There were 3 such points of fixation. So I tacked the edge of the incision down to the fascia of the muscle. Then you don't want an airtight closure on this particular lesion because fluid is bound to leak out and it will ooze for a little while. So interrupted mattress sutures, 30 Vicryl, ethylene. And then I put a pressure, I put some topical antibiotic on bacitracin in this case, some sort of T-Pact, and put a pressure dressing on it and put a roller gauze pressure dressing around the forearm. He was discharged with antibiotics, with something for the inflammatory process and pain. The pain is going to come from inflammation. So diclofenac or Bovaron is a good thing to put the patients on. Q8, every 3 hours, 3 times a day. And something, if in case something went beyond that, and I had given some tramadol also. Now, essentially, what are the instructions to give him? Obviously, keep his arm elevated, put it on a pillow. 2, don't lift heavy objects. 3, you must make movements, but not large movements, reaching up something, picking up something heavy. And I saw him this morning, absolutely comfortable, no complaints at all. Everything is coming along well. The scar is healing well. And so, in summary, we had a large lesion, which was evidenced by clinically as well as with a ultrasound imaging. We had to work under conditions wherein it had to be an outpatient chairside procedure versus in the hospital due to his economic state. We had to yet be safe and follow all the precautions, everything that we would do, mimic in an operating room, chairside. Procedure was, done in an aseptic manner. Incisions were precise, planning was accurate, the wound was dressed properly. In short, we had a very good outcome. Now, my last words to it is, if you see a large lipoma, which is sitting in a very crazy place, like shoulder area, and it's huge and it's diving down between the muscle, intramuscular, you need not go make a huge incision and create such havoc in there, like an elephant in a China factory. You can instead just let it be. What will eventually happen is the lipoma will choke. If this is a solitary lipoma, it will choke itself. Will get some cystic degeneration, and then it'll be easier to remove. All right. Now I'm not saying this is the best way to go, but if at least I'm giving you a choice, you have some thoughts in your head, or you can make a small incision, take out what you can, and marsupialize it, and just leave it kind of loosely closed. There are so many ways you can treat. Being a surgeon, you have to be able to think on your feet. On that note, thanks for watching and take care of yourself.